Yeah, so we're going to talk more about melatonin in the next session, but basically melatonin is felt to promote sleep. It's our natural substance that all of us make to promote sleep, and it also can be given, as you know, supplementally. The biggest challenge with melatonin, like any other sleep aid, is if you give too much, it can cause grogginess the next day, and then it can also interfere with the child. It's the right balance. You want to give enough to try to get the child to fall asleep on their own, so that they'll have that skill. If they wake up at night, they'll be able to go back to sleep. But you don't want to give so much that it just kind of knocks them out and then they can't. So we'll talk more about that. It was a great question. Question is melatonin effective for all kids? And that is a really interesting question from different perspectives. I think that it's effective for many kids. I don't know that it's always tried in the best light, because as I'll talk about, there's all different brands and there's all different. Now, I'm trying to refresh my memory. In Canada, it's prescribed or is over the counter, like in the U.S. Okay, so because it's over the counter in the U.S., there are all sorts of brands of melatonin. There's even some that are mixed with Benadryl, believe it or not. It's not controlled. There's not, for example, anything that says how much is in it. It's not like, that one brand compared to another brand, 1 milligram of one is going to be 1 milligram of another, whatever. So that's one of the issues why it doesn't necessarily work for all children. The bigger reason, I think, and I'm going to try to impart to you today, is that it's not necessarily combined with behavioral sleep techniques. And when you combine it with the behavioral sleep techniques, it's a lot more effective. Because it's almost like what we've learned in depression, where if you treat someone with a pill, if you treat somebody with an antidepressant, they're not going to be they're not going to benefit as much as if they have both therapy and the antidepressant. So oftentimes medicine and behavioral are synergistic, and particularly with melatonin, because the emphasis on melatonin is oftentimes to relax the child and to kind of help them settle down. So having the melatonin paired with or coupled with activities that actually help them settle down can be very, very helpful. Because I've had people say, and you may be referring to this in your question, that they've given melatonin and then it's worn off, or it only works for an hour or two and then the child wakes up. And what we're interested in studying, based on what we've found in our clinical experience, is whether melatonin plus behavioral education may be more effective than melatonin alone or behavioral education alone. That's one of the most common questions I get asked about melatonin is it effective for everyone? The second question that comes up with melatonin all the time is, what are the problems? Like, why can't I just give it to my child? Why are you such a stickler, Dr. Malow, that it should be monitored by a healthcare provider? And the reason I do is not because it's not safe, but because we don't want to miss a medical condition that may be contributing to poor sleep in the child by just giving the melatonin and hoping it will help. We want to make sure the child has been evaluated properly for sleep concerns. And this could be at the level of the pediatrician or the nurse practitioner. It doesn't have to be at the level of a sleep specialist. But that's number one, why we don't just give melatonin or ask parents to give it without consulting with a healthcare provider. The second reason is because melatonin can interact with some other medications, such as Coumadin, and other medications that the child may be using for medical conditions. So we want to be absolutely sure we're being safe. Okay, time for some more questions. Yes?
Yes, I would like to know what would you say is the big difference between
Right. So I'm really glad you made that point. The difference between night terrors and nightmares, I'm really glad you emphasized that, because I should have brought up nightmares. So nightmares tend to occur during REM sleep, rapid eye movement sleep. When our dreams occur, they're scary dreams. Night terrors occur during the non-REM sleep. So if I go back, let me just find that slide for you. Let's see, view, slide sorter, outline, because this is important. This is a good question. I want to be sure that I make the distinction. And nightmares, the child is fully awake but scared. Night terrors, they may not be awake at all. They may be still asleep. Like, remember those high delta waves I showed you on that child on the video? So, here we go from current slide. Okay, so the nightmares are occurring out of REM sleep, which is here, 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 and here. And usually, most of the nightmares are going to occur when the REM sleep is the most, which is toward morning, which is also when we tend to remember our dreams, the dreams toward morning. In the night terrors and the sleep terrors, and the night terrors and sleep terrors are kind of used synonymously. And the sleepwalking, that's more in the first part of the night during this deep sleep. And in the nightmares, the child is fully awake but scared. The night terrors, they may look like they're awake, their eyes are open, they may be screaming inconsolably, but they don't remember it. They're amnestic for it. They're still asleep. So that's the difference between the two. Okay. Sure.
Is it possible to have your child to have seizures, say, at night, but be completely normal throughout the day, like you wouldn't even guess it? Or does it fall into the same thing? Would they have seizures during the day?
Right. There are forms of nocturnal or totally sleep-related epilepsy where the seizures can be limited completely to the night. And a good example of that is that benign Rolandic I showed you with the kid who was moving the side of his mouth. Some of the frontal lobe seizures, the young girl I showed you who put the arm over her head with the fencing position, she only had seizures in her sleep. So certain types of epilepsy are limited to sleep. And we don't exactly know why. It may be that the connections between the brain areas that promote sleep and epilepsy are more active in those. But certain types of epilepsy are only during sleep. So it can be very challenging because it might look like something else. It might look like another sleep-related event. The other thing that's hard about seizures in your sleep and making the diagnosis is during the day, if somebody has a seizure, people are around. During the night, you know, that by the time the parents are alerted, the child's seizure may be over. During the day, oftentimes you can describe a funny feeling that you have. Again, it might be hard for our kids with autism to describe it, but funny feeling in the stomach, butterflies in the stomach, whatever. When you're asleep and you're having a seizure out of sleep, you may miss that. So seizures during sleep are really hard. Oftentimes you want to take that extra step if you're suspicious to do the overnight study. The other thing I should mention, we will sometimes see on the overnight study, even if we don't capture a seizure, we'll see funny brain activity like the examples I showed you, that we call it interictal or in-between seizures, and it can be very helpful. Like this activity here might come out even if you don't have an actual seizure, and that could be diagnostic. Yes?
With melatonin, because our body produces some of it anyway, it's thought in kids with autism they just produce less. If you then go and supplement that, is there any suggestion that our body would then in turn make less or compensate so that over time you'd need more?
That's a really good question. Let me address both of those, because there are some studies out there showing that melatonin levels in kids with autism are less than in kids who are typically developing. But it's not definitive. We actually just published a study in the last couple of months. It's in the Journal of Autism and Developmental Disorders if you're interested. And I'd be happy to send it to post on the ACT website, showing normal profiles of melatonin in 9 kids with autism who are participating in our melatonin study. What it was we drew their blood in our clinical research center using a catheter, so we only had to stick them once, and we did these overnight blood draws. And we did it before we treated them with supplemental melatonin, and then at each subsequent time. And we actually we thought we were going to find low levels. We did not find low levels. We found normal levels. We found that the timing of melatonin was normal, of their own melatonin. And we also found that when we gave them the supplemental melatonin, they metabolized it normally. And that was pretty remarkable for us because, as I said, there had been studies in the literature, mostly older, some using melatonin levels during the day, which don't necessarily equate with what's going on at night, some that used urinary levels of melatonin and had found deficiency. So we did not find a deficiency, making us wonder if there's other things going on. Maybe melatonin isn't treating a deficiency in these kids as much as it's treating like that hyperarousal, that cortisol that we talked about earlier. So that's point number 1. I think there's a lot more that has to be done before we say that kids with autism have a melatonin deficiency. Because at least in the small sample we didn't find it. And these were kids who were actually being treated with melatonin, who were going to be treated with melatonin. We did the levels before they were treated, of course. The second point you make is certainly something that comes up a lot. If we do give melatonin to these kids, regardless of whether they have a deficiency or not, could it somehow interfere with their own production of melatonin? The company that I mentioned in Israel who's doing this extended release melatonin study did some careful studies, and they actually found that it did not interfere with it as best as they could tell. But I think more studies are needed. My sense of things is that while kids who are on melatonin do not generally need more or higher doses, we sometimes do see that over time it's not as effective. But I wonder if that's less about the melatonin and more about either they're moving into adolescence and they have different sleep challenges, or the behavioral is not being necessarily implemented to the same extent that it was in the beginning. So I think it's worthy of more study. I tend to keep kids on melatonin and not worry too much about that, because what I found over time is the kids you keep on the melatonin do better than the kids who've come off of the melatonin because their parents thought they needed to have a break for a week or two to try to, reinstate their levels, because I'm not sure we've really proven that they do need to have their levels reinstated. Yes?
Could you comment on certain developmental periods like puberty and how that can affect insomnia or cortisol levels or melatonin?
Yeah, so the question is puberty and what role does that play? And that's actually a section in this new toolkit, which I'm really excited about, is it gets into all the different changes. I think the biggest change that we see with puberty is actually gets back to melatonin. We see that as kids transition into puberty and adolescence, they tend to go to bed later. In fact, typically developing children, about 10 to 15%, can have something called delayed sleep phase syndrome, which is exactly what it sounds like. Your sleep phase, your time that you go to sleep and wake up, is shifted. It's delayed. And when I was growing up, I don't know about you guys, it was called being a teenager. It was going to bed late and waking up late. But now there's this biological reason for it, and people have actually shown that melatonin levels, and I'm talking about typically developing teenagers here, melatonin levels are actually later in those kids. So the amount of melatonin is normal, but they secrete it later in the night than you would expect, later in the evening than you would expect. Melatonin is the gatekeeper of sleep, or one of the gatekeepers. So the idea is that you have your melatonin release and then you fall asleep. And in these teenagers, what they found is they were secreting their melatonin later, and therefore they were more apt to have a later bedtime. The reality is probably a combination of both the biological as well as the behavioral, because in addition to the change with puberty and adolescence where our melatonin is secreted later and we tend to have a later bedtime, we also have all of the societal influences of staying up late, getting homework done, socializing with friends. One of the biggest challenges we see, not just in our kids with autism, but in our general, typically developing population, is this tendency to stay up late on the weekends. And then in the Monday morning, they have to get up for school, and they can't get up for school because they're used to not only going to bed at midnight or later on the weekends, but then sleeping in on Saturday or Sunday morning until noon or even later. So it's very hard to then readjust on Monday morning and get back into that routine. So that's all what we're learning from the typically developing literature. In autism, we really don't know what's going on. We suspect there may be a higher prevalence of the delayed sleep phase, but we don't know that for sure. My colleague Suzanne Goldman at Vanderbilt is conducting studies looking at cortisol, looking at melatonin, looking at actigraphy to try to get a feel for what adolescents with autism are doing, whether they're good sleepers or poor sleepers, and seeing if we see any differences. But we haven't really sorted through the data there yet. Yes?
Children with these events that you have up on the slide now, is it always problematic? Like, are there kids with these issues that don't have disrupted sleep that doesn't affect their function?
Yeah, that's a great question. I bring these up because this is what parents are concerned about, but I mean, the seizures would probably be, of concern. I mean, you'd want to at least know about them, diagnose them. We don't necessarily treat all kids with seizure disorders with anti-epileptic drugs, particularly if they're occurring once a year. The benign rolandic epilepsy is a good example of that. They're not driving, we don't have to worry. If they're felt to have a relatively benign, rare seizure, we'll sometimes just watch and wait, or particularly the benign rolandic, they oftentimes will outgrow. The other ones are really much more benign, particularly the sleep terrors, the sleepwalking. They may occur in a setting of emotional stress or just sleep deprivation around the holiday season. The most important thing there is if they're occurring even once a year, you still want to be sure the safety measures are in place. So if the safety measures are in place, we've been able to evaluate them medically and feel that they're benign. They're meeting all the things we want. So let's say, for example, with sleepwalking, it's the first part of the night, there's a family history, it's only occurring when the child is sleep deprived or there's a lot of stress and excitement going on in the family. The family has not noted anything unusual like jerking of the movements or movements of the mouth or anything that makes you think seizure. They're only occurring, rarely. Then the only thing I would make sure is in place is the safety measures. And other than that, making sure there's no underlying sleep apnea or other cause, I would just observe. I wouldn't necessarily treat. The other extreme might be, the young adult, and I'm speaking not about autism here, I'm speaking just in general about anyone with these conditions. The young adult who's going off to college, who's on their own, who doesn't have a roommate, who lives on a high balcony floor. that's somebody I'm going to move to a lower balcony for, try to get with a roommate, do those kinds of things to make sure that they're not going to hurt themselves during one of these episodes. Yes?
Is there an age time when the sleep terrors or sleepwalking start, or a time when they're more prevalent?
Yes, the question is, what about the age time? Usually 2-3 years around for sleep terrors, and about that age, a little bit older for sleepwalking. And usually by teenage years, the night terrors oftentimes sleep terrors normally they should resolve even by age 5, 6, 7. Sometimes they can last longer. The sleepwalking can last longer into the teenage years. And occasionally we'll see young adults who continue to have sleepwalking or sleep terrors. What would be a red flag that would make me want to study these individuals more is if they develop the sleepwalking or sleep terrors later in life, like in teenage years, and they haven't had it as a child.
I have some families, and I don't know if it's just coincidental, but they've reported when they've used melatonin that it was the first time the child had an episode of a sleep terror. And you mentioned like 3 side effects of melatonin from this study, and sleep terror wasn't part of that. So do you think that was maybe just a coincidence? I'm in pediatrics, so these children are between 3 and 4 years. So.
Yeah, it's interesting. We specifically looked for sleep terrors and seizures being more prevalent when kids started on melatonin, and we did not see it either in our, in our retrospective study or in the prospective study that we did, meaning we actually treated kids and followed them forward. But it has been described in literature. The seizures I don't necessarily believe, because there was only one report of increased seizures, and many other studies have not shown the increased seizures. Other studies have talked about sleep terrors potentially being more prevalent, and it almost to me seems to be in the same category as what I mentioned about the bedwetting or the nocturnal enuresis. In order to have a sleep terror, you have to sleep, right? So it may be that these kids were prone to sleep terrors, but because they weren't sleeping, so we may actually, if I masked something with the melatonin, not that the melatonin was causing the sleep terror, but it was actually allowing them to sleep. So I don't really know for sure. I do know that in our retrospective review of 107 kids, the families were very pleased. Most of the kids were sleeping quite well. It made a big difference in terms of how they were functioning, and it probably made up for, in general, it would be a good thing as compared to not putting them on it and not having the sleep terror. But your point is well taken. Let's see, in the back.
How do you know when to take your kid off melatonin, and how do you know that they're sleeping well?
Right. So the question is, how do you know when it's time to take your child off melatonin, and then when you take your child off melatonin if they're sleeping well? Yeah.
How can you tell they're sleeping well if they're on melatonin?
Oh, okay. So in terms of knowing if they're sleeping well on melatonin, I think combining parent report, combining what you observe about your child with potentially saying to your doctor or healthcare provider, can we do some actigraphy, would be great. And that may be where you want to get a referral to the sleep specialist. There are things on the market like Fitbits and all. They're not validated. I'm not saying you couldn't use them. I prefer to use the actigraphy, but then again, I have families come and see me. But that's very helpful because you can actually monitor what they're doing and make sure, because as the kids get older, sometimes they'll wake up and you won't even know that they're up. In terms of when to take them off of melatonin, what I'll do, sometimes a child will initiate melatonin and behavioral measures together because the family is just really overwhelmed. And what we'll try to do over time is do more and more behavioral measures and then see if we can stop the melatonin, because parents oftentimes would like their child to be on as little as possible. It's good practice to not be on, try to be on no meds rather than anything, and just see what happens and see if we can kind of substitute the behavioral. Also, as the child gets older, they can learn, they have more tools. They can learn how to self-soothe more as they get older. So I think that it's certainly worth a try. I don't worry too much about it or stress too much about it. If the child needs it, I'll keep the melatonin going. I have children who've been on melatonin many, many years, including into their adolescence, without any detrimental effects. But I will try, certainly I will try to withdraw it if the parent feels like that would be their preference, usually in combination with implementing behavioral strategies. Yes?
I have twins with autism, and both have sleeping problem. There is any particular study for especially for twins or multiples?
So, sleeping problems in twins with autism? I don't think so, other than I've had twins and even triplets in my practice who I've treated, and the parents have been able to kind of do, like, just incorporate both kids into the bedtime regimen. It's interesting to me, sometimes there's differences. Sometimes they'll both be on the autism spectrum, but one may have more severe sleep problems than another, or one may be, they may even be different problems, like one may have problems falling asleep while another may have more problems with night wakings. I'm curious, do your twins sleep similarly, or?
Yeah, I use melatonin to put them in sleep, and it seems working well. But they both wake up middle of the night. But it's not usually the same night. It seems like they are taking turns. Like I don't sleep, but sometimes they can sleep. And, like this month, like one is waking up all the time, but the other one is sleeping well. And next month, this one is waking up all the time, and the other one is sleeping well. And I'm like, I don't get sleep all the time.
Oh, no.
Somehow they are getting sleep.
Yeah, so what I would say is try to come up with a plan, and we'll talk about it this afternoon, that works for both of them, and try to be consistent with the bedtime routine with both. And the more you can do with both, I know, my heart goes out to you. And we'll also talk a little bit this afternoon is things can change over time. So you're right, you could have with just one child and they're sleeping great for a while, and then something new happens, and things get out of kilter. And if you multiply it by 2, you have more possibility of that happening. But let's try to talk some more this afternoon when we talk about the behavioral.